Onc Live Insights is a video editorial program produced by Onc Live.
PI3K mutation is a potential biomarker that has been studied in colon cancer in patients who are receiving EGFR drug. We know that EGFR drug activates two pathways. One is the KRAS, the RAS-RAF-MEK pathway, which has been studied some extensively, and the other pathway is the PI3K-AKT-P10 pathway. Now, we know that PI3K is one of the biomarkers that has been looked at. It's been sort of a controversial in terms of the prognostic nature of this marker. However, in terms of the predictive value, it's been looked at in two areas. The hotspots is exon 9 and exon 20, and it occurs in about 20% of the patients with advanced colon cancer. And there's some data that if you have mutations both exon 9 and exon 20, is actually a poor prognostic feature. But in terms of the predictive value of being resistant to EGFR drug, the data currently out there is mixed in terms of the nature of the value. However, when they looked closely at the exon 20 mutations, they found out that patients with PI3K exon 20 mutations are the patients that are actually resistant to EGFR drug, most likely because it is independent of RAS binding. However, in the patient with exon 9 mutation, with PI3K exon 9 mutation, those patients actually were not resistant to EGFR drug because the PI3K exon 9 mutations are dependent upon the RAS binding. Having said that, the numbers of PI3K exon 20 mutations are very small, in 2 to 3% range. Therefore, we need larger studies to be done to validate its finding and its clinical implication.
The PI3K gene, an important gene in a variety of cancers, is mutated somewhere in the range of 15 to 20% of metastatic colon cancer. There have been many drugs under development to target the PI3K gene and in a variety of malignancies, but so far those drugs aren't working for those patients with PI3K mutated tumors. We need better drugs. The gene's important. It's a major driver in colon cancer, but we haven't been able to effectively target it. What is interesting is that there have been some studies to suggest that if your patient's tumor is mutated in PI3K, you may be less sensitive, less responsive to EGFR antibodies. I think that's controversial, but it has been suggested, and I think more needs to come out there. The other thing is we actually have a study from our center where we found that patients with earlier stage disease who took aspirin seemed to do better. So if they took aspirin in conjunction with their standard therapy, they had a better outcome. Aspirin appears to have an anti-proliferative effect on colon cancer. What was interesting from our study, published in the New England Journal of Medicine about a year ago, was that if your patient's tumor had a PI3K mutation, you had a significant, even greater benefit if your patient took aspirin in conjunction with their therapy. Now, I think that's one study. It needs to be confirmed. It was a large study, but it's interesting, and maybe that might be one area, at least today, where knowing the status of PI3K may inform what is a very inexpensive and easy addition to therapy, namely taking an aspirin.
For PI3 kinase, there's not a lot of agreement among different studies on its exact interaction with EGFR agents and development of resistance. The most exciting data that exists for PI3 kinase is in the use of COX-2 inhibitors and aspirin to either prevent cancer or to prevent recurrence of cancer, or to prolong survival, even in patients with metastatic disease. So at ASCO last year, there was a very large study done from Norway, where they have very good long-term data on their entire population, looking at aspirin use in patients who had colon cancer stages 1 through 4. And so they didn't differentiate. And what was seen was exactly what was seen in the health professional study in the US, the nurses study in the US with aspirin use, is that overall survival was improved. And no one quite knows why this is true, although aspirin is a COX-2 inhibitor. And there is data also for the NSAID COX-2 inhibitors in improving survival. But these data, nicely discussed by Andy Chan from Harvard, stand in complete agreement with at least 15 prior studies. Now, all of these are retrospective studies, but the data are pretty profound, where people not only have better survival overall, but they have better colorectal cancer survival. So people develop fewer tumors, second tumors. They develop fewer tumors altogether. Then when they get colon cancer, they do better. So one would ask the question is, why not use something simple and cheap like aspirin if it's good for you in this regard? Well, a number of groups in Great Britain and the US have discussed this thoroughly and have come to different conclusions. People worry obviously about bleeding rates vis-a-vis the use of aspirin versus colorectal cancer or cardiac benefits. And I think the difference is not so much a qualitative one. Everyone agrees that it should be useful. What they disagree on is the number of patients who might have a bleeding event versus the number who might benefit, the number needed to treat. I have to tell you, when I look at the numbers, I take aspirin. That's my answer. That's what I do. And one further thing in regard to PI3 kinase, the people who seem to benefit almost all are those who have PI3 kinase mutations, which is 15%. All of these studies, when they go back retrospectively and have the tissue available to do it, show that there's no benefit if you don't have the PI3 kinase mutation, and a huge benefit if you do. There are about 5 aspirin intervention trials underway. Only one of them is collecting the PI3 kinase mutations up front. They're collecting tissue, but they're only collecting it up front. And they're not randomizing patients with or without, whether they have the mutation or not. So that's a good part. We have prospective trials underway. The bad part is that it will be at least 15 years before we get the data from these studies, because we're looking at large numbers of patients who need to be treated. The studies will take at least 5 years to accrue, and then one needs at least 5 to 10 years of follow-up to see who's benefiting. So for the moment, when I finish adjuvant therapy in a patient, I don't tell them that their treatment is over, because there are so many other things that Charlie Fuchs and his colleagues at the Farber have told us about how also to prevent recurrence beyond chemotherapy. One of them is diet, one of them is exercise, one of them is vitamin D, and then finally, one of them could be aspirin, especially for those who are PI3 kinase mutation. And I think more people will be looking for that in their practices, will be looking for this mutation to select people who are at low risk for bleeding and potentially high risk of benefit from aspirin.